Okay, hello everyone. Good afternoon. And I'd like to welcome you to our webinar on improving communication in intensive care units. We're going to describe our project today, which we've been working on for about the last year and a half. It's a collaboration between three organizations, which are shown on this slide. It's Southern California Kaiser Permanente, PFCC Partners, and Los Angeles County Department of Health Services. So if I could have the next slide. I'd like to begin by introducing you to the project team. My name is Dong Chang, and I'm a pulmonary and critical care physician at Los Angeles General Medical Center in the Los Angeles County Department of Health Services. My partners are Libby Hoy, who is the founder and CEO of PFCC Partners, and Glenna Chang, who is a pulmonary and critical care physician based out of Kaiser South Bay in the Southern California Kaiser Permanente system. So next slide. So here's our session objectives. We'd like to describe our project to improve ICU communication. We'd like to share some early learnings with this amazingly broad and diverse audience that we have today. And then we'd also like to get some additional insights and feedback on what we've done so far and how we might move forward. Next slide. So to do that, here's our agenda. I'd like to introduce you to our project, which is basically a capacity building project to develop a research community here in Southern California that centers around the objective of improving communication in intensive care units and having stakeholders participate in patient-centered outcomes research for that goal. We're going to describe some of our methodology, which includes using a knowledge map and training people through a skills exchange, and we'll go into more detail on that. We've also tasked our research community to work on improving a known intervention for communication called a time-limited trial, and we'll dive a little bit further into that. We'll also have a panel discussion from multiple stakeholders that have experienced the project so far and get their perspectives, and then we'll end with some input from the larger group. So prepare to participate. We'd really love to hear from you in terms of your thoughts. Next slide. So at this point, I'll hand off to one of my partners, Glenna Chang.
Good afternoon, everyone. I'm Glenna. I'm one of the project team members, and what I'd like to share with you guys today is to acknowledge our funder for this research, PCORI, which stands for Patient-Centered Outcomes Research Institute. For those of you who are not familiar with PCORI, it is an independent nonprofit research organization that seeks to empower patients and others who have actionable information about health and healthcare choices. So their main mission is to fund comparative clinical effective research, which basically is comparing two or more treatments or services or practices to see what works better. And PCORI's unique mission is actually to make healthcare more patient-centered. So that's the driving force of the research that it funds. In addition to funding projects that compare different methods in medicine, it also promotes engagement awards, and which is what our project is. It's an engagement award, the Eugene Washington, specifically PCORI Engagement Award. And what our engagement was our mission was to develop a community for engagement in this type of research and to build capacity, like Dong said, so that we could equip patients and other stakeholders with the skills that are necessary to participate in this kind of research. And then from that mission to then scale up and adopt meaningful tools to involve more community stakeholders and patients. And so that's how we came up with this project, thanks to funding from PCORI, to build capacity to improve intensive care unit communication together. Next slide, please. So we had three aims for our project. The first one that our project team sought out to achieve was to create a steering committee, and a steering committee of people to help us guide, recruit members for our research community, and then to develop effective and respectful ways to create a training curriculum, and then meeting agendas for our research community, and then to raise the capacity for research training and partnership. So with the help of our steering committee from AIM 1, it leads us to AIM 2, which is to develop this research community to ultimately achieve aim 3, to have people become active participants in patient-centered comparative effectiveness research. And this leads to these projects that Libby will describe later, are in-person skills exchange, and then secondly, improving an existing tool that is in the literature, that what we call the time limit trial tool. Next slide, please. So just so you, oh, one back, there you go. So just so you all understand, again, in concordance with the mission of PCORI, is to make sure that we involve all sorts of stakeholder groups in our research community. I think traditionally research involves health services researchers and the clinicians. But here we want to make a very big focus, and that's the top arrow, on patients and family members with lived ICU experiences. So we did we've really tried to use Libby's connections and our connections to different patient family partners to involve this segment of our stakeholders into our research community. Of course, we also have ICU physicians, palliative care physicians, and ICU and palliative care nurses involved in this research community. We have many great social workers who are involved. We have chaplains, bioethicists, healthcare administrators, and again, our traditional researchers, so that we can all participate and contribute to this project. I'm going to hand off next slide to Libby, please.
Hi, everyone. And yeah, thank you so much for joining us today. I'm just going to take a quick second to make sure that we're recording all this great content. If Lindsay could start the recording, that would be great.
Yes, but got it.
Got it. Thanks. So yes, what we did was convene the multi-stakeholder research community that Glenna just reviewed, and through a series of online virtual meetings, we created this knowledge map. Like, we felt that really strongly, that if the people in the room had the answers, had the knowledge together, if we all kind of worked together. So we did this knowledge map to map out who has what knowledge. Patients and family caregivers have a lot of knowledge about how it feels to be effectively communicated with, and clinicians obviously have tons of knowledge about specific conditions. And so how could we really kind of bring all of the knowledge of the room into a really effective process for moving this project forward? So after these series of virtual meetings where we developed the knowledge map, on the next slide, we hosted an in-person skills exchange. So this was an exciting day to bring the whole research community together. I believe there were about 40 of us in the room. Again, all stakeholder groups represented. And we did a little seating chart, like the wedding planning thing, where we had everybody sit together and kind of disperse, both from the perspective they were representing, but also from the facility or organizations that they were representing. And we had a few objectives. We wanted to, first of all, build the capacity of the research community by sharing existing knowledge. Again, I think the great quote from Don Berwick, "Move knowledge, not people." That's what we're really trying to do, move the knowledge that we each had. Secondly, we wanted to identify priority areas for future research to improve ICU communication, particularly about non-beneficial treatments. That was really kind of the focus of our project. And then thirdly, to challenge the research community to learn in a new and collaborative learning format. It was really different. We had all kinds of things going on. And I will say that the research community itself helped to develop the agenda for the in-person. So I will tell you, I would not have put role-playing on the agenda, but our research community felt that was a really valuable way to learn. And so we did that. We did that sort of interactive work together. So let me turn it over now to Dong to tell us, everybody, what we learned.
Thanks so much, Libby. As Libby mentioned, this was just a wonderful day, and we learned quite a bit. We tried to summarize some of the learnings and some of the input from the stakeholders about improving ICU communication in this following format on this slide. So we were really drilling down on, as we move this forward to research projects, what are the things that we really need to pay attention to? And so some of the feedback that we got related to characteristics of interventions to improve communication. That included things like we communicate as a multidisciplinary team, and the training should really reflect that we should train ICU physicians with nurses, with social workers, everybody together as a team, because that's how it happens in real life. In addition, really the timeliness of the communication was emphasized so that we can have mutual expectations with our patients and our families about what the ICU hospitalization will be like, what the treatments will be like, and so forth. And then, of course, there was an emphasis on really promoting honest and authentic communication that promotes information sharing. And so that's kind of the context in which interventions should be developed and some of the things that we might pay attention to. But there were other several modifying factors that needed to be considered as well from the perspective of our multi-stakeholder group. Those included recognizing that here in Los Angeles County, we have an amazingly diverse patient population, and the diversity in race, ethnicity, and culture, as well as health literacy, really should be recognized and addressed. In addition to that larger diversity, every family brings their unique story, their unique experiences with illness, with ICU hospitalizations, with interactions with healthcare to that particular encounter. And we really need to honor and recognize that as we communicate. So those were some of the key modifying factors that we were asked to consider. And then as far as outcomes, in addition to assessing the quality of the communication, our stakeholders really felt that we should pay attention to things that resonate with individual stakeholder groups. So as an example, patient family partners naturally gravitated towards concepts such as patient suffering, while as health services researchers or health leaders might focus on healthcare utilization, such as the length of the hospitalization, the use of invasive procedures, and so forth. So those are some of the key learnings. If we can move on to the next slide. So after the skills exchange, we then tried to apply some of the lessons that we learned and some of the skill sets that are being developed in this research community to a specific task to really catalyze and develop those skill sets further. And after discussion with our steering committee, what we felt was that having the research community work on a particular problem was another way to really catalyze the development of a research community that can participate in future projects. So what we thought of was trying to have the research community improve on an existing ICU communication tool, and that's called the time-limited trials tool. And I'd like to just take a step back and describe a little bit of what that means and provide you a little bit of context so you can understand the purpose of doing that. So I will say right off the bat that this was not an easy task that we put to our research community. And I think we can all agree that in general, communication in intensive care units is very challenging. But what we tasked them to do was actually address a tool that is talking about communication at one of the most sensitive times. And that particular time is when ICU teams feel like perhaps some of the invasive procedures that we're going to offer, they may do more harm than good. And the reason one might feel that way is that if a patient has very serious advanced illnesses, examples being advanced dementia or terminal cancer, we're oftentimes put in a situation where clinically we have to think about whether some of these life-saving interventions would actually end up prolonging suffering and doing more harm than benefit for our patient. And that is a really challenging conversation to have. The time-limited trial communication tool is actually something that we've developed that addresses that particular scenario. And what we asked our research community to do was work on that and see if we can have improvements in that particular tool. So I'd like to describe what a time-limited trial is. As you can see on this slide, it's an agreement between clinicians, patients, surrogate decision makers to use certain medical therapies. The example that I gave you is mechanical ventilation or the breathing machine, but it could be other things such as dialysis, really over a defined period of time, and to observe very carefully to see if the patient improves or worsens. And we observe that using clinical outcomes that are the most predictive of prognosis. So it's a relatively simple concept that we try to utilize potentially invasive treatments for a period of time, observe very carefully whether a patient improves, and then make some decisions from there. If we can have the next slide, please. So here's the set of interventions and the bundle that we developed to try to change clinicians' practices and communication. And that bundle is shown in the center box under interventions. We had a time-limited trial protocol and checklist. What that consisted of was 2 different columns. On the left side, a checklist of items that clinicians should talk to families about. And on the right side, a set of phrases that they might use as examples for how to accomplish that conversation. We also had provider education and training. In general, that education and training consisted of some lectures and some didactic sessions, as well as some focus groups to talk with clinicians about their concerns, clarify any misunderstandings. And then we had some simulations where the clinicians got to practice using the protocol and communicating in a time-limited trial format. We also had templates for the electronic health record, some feedback meetings, and then a meeting coordinator to facilitate scheduling of the meetings between different groups, patients and families, and so forth. And the reason why we came up with this bundle of interventions was that we really felt that it addressed some of the key factors in the capabilities, the opportunities, and the motivation that our stakeholders mentioned were problematic when trying to have consistent communication in this way. We were really pretty excited about the results that we got in a pilot study that utilized time-limited trials as the baseline communication practice for patients that were really at risk for receiving non-beneficial ICU treatments. What we found in this pilot was that it improves the quality of communication with families. It reduces the length of ICU hospitalization without affecting patient survival, and it decreases the use of invasive non-beneficial treatments. So we were really excited about this. But what was also very clear to us was that there were things that were missing. In our haste to create an intervention that was effective, what we didn't do enough was to get input from the stakeholders that are really involved in this process. That included patients and families, it included clinicians, and really it included the health leadership that supports this sort of process. And so in the next iterations of what we wanted to do, we really wanted to emphasize having stakeholder input and really improve on the first steps that we developed with the time-limited trial tool. And so as a result of that, marrying the 2 processes, we thought that a research community could really, really help us in terms of improving this particular tool. Next slide, please. Here are some of the amazing thoughts and themes that came out as a result of these discussions. And I find these absolutely wonderful and fascinating. Some of the questions that we asked of our research community are shown on the left there. You can see that they're very open-ended questions, such as what's missing from the tool? How can it be improved? How do we know if this is working? And what we're showing you on the right side are just some of the themes, just some of them that came out in terms of how we improve the time-limited trial intervention. Our stakeholders felt that families really differ in time needed to absorb and understand bad news. In other words, for a time-limited trial, we need to be very, very careful and understand that sometimes just the amount of time that we set is not enough. Sometimes 1 meeting is not enough. We really have to be mindful of the fact that it takes time for adjustment, and we need to be very, very flexible in that. It was also felt that time-limited trials may feel like we're taking something away at the end of that trial. And we really have to be sensitive to that and perhaps frame it in a light of we are actually giving the patient the best possible opportunity to improve and really focusing on whether that improvement is occurring. In addition, we have to definitely address potential misperceptions that a time-limited trial may be a way to try to save money or limit healthcare, which it really isn't. It's a communication tool, but we have to address that up front so that these miscommunications and misperceptions don't occur. And then the next point is a fascinating one. We use the term time-limited trials because that's what's described in the medical literature when we communicate in this fashion. But our stakeholders felt that this was just, it had such negative connotations that it really invoked bad emotions and feelings. The idea of limiting something after a period of time, or the idea that a trial might hearken to experimentation, really rang poorly with our research community, and we need to definitely recognize that. We'll talk a little bit more about that. In addition, they really emphasize that we need to maintain continuity of plans across different care teams, and we need to focus on some key patient-centered outcomes, which are listed there. But I want to actually engage you guys on one of the fascinating things that came up, which is this idea of calling it a time-limited trial. I'm going to hand this off to Libby, and we're going to actually get your input in terms of what you think about that particular terminology.
Yeah, I think we got so many great ideas and for improvement, but I think unilaterally almost every stakeholder group and every stakeholder felt that we could improve the name, or that we could come up with a name that would do it justice. So I would love to invite all of you, because I'm really into hearing from many, many different diverse perspectives. After hearing the explanation of what the intervention is from Dong, what would be a better title for that? So I would invite you to hold your smartphone up to that QR code and go straight over to a poll and give us your thoughts. Anything goes. You can also, if you don't have a QR code or your phone available, you can go to the website at slido.com and put in the poll number that you see there, 5347243. And we'll be using this a couple times, so go ahead and get that set up for you. Ooh, all right. I see some populating. That's fantastic. Family and clinician communication tool. Treatment plan discussion. Oof. Discussion just sounds so much more inviting, doesn't it? I love that. New intervention analysis, patient-driven, time-limited trial. Okay, so keep the time-limited trial, but add patient-driven to it. Awesome. Consistent communication tool. Love that. I knew this was going to be a helpful crowd. Thank you so much. All right, we'll let those continue to roll in. But at this time, I would love to invite our panelists. We have a great quick session for us today, but really wanted everybody to hear the different perspectives that are represented in our research community. And so we have Kelly Cardenas, who is an ICU nurse, Maria Arak, who is our patient family partner, and Dr. Brian Mittman, a clinical researcher. So let's see, do we have everybody? Are you on camera? We can take down that slide deck too, Lindsay, if you get a chance. All right. So Kelly, if I can start with you, what is the value of community-based research?
Hello, everyone. Happy to be here. Definitely as a participant in this research project, I've been able to experience the significance and value that all of us stakeholders have been able to bring to the research, or to this research in particular. For instance, I would say it has allowed us all to contribute our own experiences as it relates to the ICU setting. It also it's allowed for a safe space for us all to be active participants. I think even though some of us came in a little apprehensive, especially with role playing, I think it was so well done and thought of that we all participated equally, which was also significant. I feel we've all been able to be equal partners and collaborate together as we share our own experience, like I mentioned already, in a safe space, which is huge. We've been able to be co-learners as well, as we all are. It's a very diverse group. And so with our own experiences as clinicians, even as community members, I think that it's been valuable for us all to learn about each other and how we all bring uniqueness to this research. And as it relates to a healthcare change that we want to promote, it doesn't feel like it's a group of individuals trying to promote change for, but with the community, which is, it's significant. I think it adds value in the sense where it's valid and people will be more apt to adopt because we're such a diverse group.
Thank you, Kelly. I couldn't agree with you more. I think the value of having all of the different perspectives, just like in this panel, present and contributing only helps us to create an evidence base that really works for the community as it is. So I appreciate that. Dr. Mittman, is there anything that surprised you about this process?
Certainly, and first of all, my thanks as well for the opportunity to participate. And my apologies, I'm getting over a cold, and we'll hope that my cough doesn't break through. Yeah, I'd like to talk about a somewhat narrow issue, and that is the what the researchers and research community label generalizability or transferability. The idea that what we develop in terms of innovations would ideally be relevant for, suitable, appropriate for lots of different kinds of situations. To use a relatively simple example, when we develop and study a vaccine, the hope is that vaccine is effective for all patients. That concept of generalizability or sort of universal relevance rarely, if ever, is seen when we deal with the kinds of innovations that were the focus of this project. And what struck me was the extent to which that's the case. And in some ways, many of the situations here are sort of the extreme end of non-generalizability or non-universality, if that's the appropriate word. When we deal with the challenge of improving communication in the ICU, first of all, we're dealing with end-of-life issues for which there is arguably more emotion than just about any other kind of decision. One of my current projects is trying to encourage patients to reach a decision on how to treat appendicitis, where in addition to the usual surgery, you can now opt for antibiotics. That decision has consequences, but not nearly the same level of consequences as what we're talking about in this project. So that extreme set of challenges is one key factor that really means that what we're doing here is both more challenging, but also not necessarily going to be widely applicable. Although we could argue that if we can solve this problem, the tool is likely to be usable for much easier problems. Another feature, though, that is one of the challenges is the fact that there are competing considerations, sort of pros and cons. There is no right answer, and the number of different considerations that have to be taken into account that we have to discuss and essentially reach trade-offs in order to decide on balance what is the best course of action, knowing that that best course, in quotes, is the best on only one or two considerations. And for many of other goals, it actually is one of the worst options available. So again, no right answers, no easy answers, and the challenge of developing a tool that will support the kinds of education and information sharing and raising and discussion or consideration of the different goals and how each of the options performs or stacks up relative to that goal is extremely challenging. And then the final factor that I wanted to mention is the number of individuals who really want to be and need to be involved in the decision. Again, going back to my simple appendicitis option, I'm in the emergency room, I have pain, I'm told that I could have surgery or antibiotics. I sort of think through for my own self, how I feel about the different pros and cons, of which the list is much shorter. But it's basically my decision, perhaps with a loved one. I wouldn't necessarily involve my kids or other family members. So again, the number of individuals who really need to be involved in the decision adds yet another layer of complexity. And on balance, my feeling as a researcher is that because of all of those challenges, the tool that results from this project and the insights and experience that we gain in using it are likely to be useful for all of those other arguably easier problems that we have to deal with, where we are trying to improve shared decision making and knowledge and understanding.
I really appreciate those insights, and certainly doing this sort of work is challenging in a challenging environment in the ICU, as you articulated so well. I think the other thing too to take away is when we're designing research together with multiple stakeholders, that's difficult, right? It's difficult to come together and create that safe space that Kelly was just referring to, so that everybody is a full contributor. But and as specific as this topic is, and hopefully, like you said, we can see some ability to use the tool in other areas as well. Perhaps too, we're helping others to see how a diverse, multi-stakeholder research community can help us move those along the way. So really appreciate that perspective. Thank you. And Maria, our patient family partner, thank you so much for joining us today. I know you've been in a lot of different spaces and you're a great community representative as well. What have you learned in this project about working effectively with other stakeholders?
Thank you, everyone, and good afternoon. My very goal is for education and awareness. This is my first came to my mind. It's essential to educate the community about the importance of planning for disability, of providing information early, and helps individuals and families understand the options and prepare for the future, reducing the need for rushing decisions during the stressful times. That's the first session I learned. And thank you for inviting me and be part of this, because now I'm gonna advocate for that. Facilitating open and honest conversation within the families and disability planning is crucial, because I have disability. My mother is 86, and this discussion is help to ensure that everyone preference and concerns and ahead consider, leading or more informed to lead stress decision making when the times is come. And the times is gonna come. We never know. If we can be young, but we can have a sickness at the accidents like me, and this is one more I learned in this project. And thank you again for being part of this, because this is helping to know what is needed in the community. And this is something I'm working now to help the people and families to how to decide when an individual has to lose capacity, and they don't need to have a lawyer or any agent, that they can do it on their own with help with the doctors.
Mm-hmm. Thank you so much, Maria. You made so many great points in there. And I think that, you know, the idea that when we engage people and family caregivers, patients, community members into the process of developing our projects and our interventions, they then become sort of our messengers, right? You talk about building awareness and advocating for the idea that people think about these decisions before they get into that situation. And I think that's a real high value sort of not necessarily organic outcome, I guess I could call it, of engaging people with lived experience, because they go back to the community and share that awareness, share what they've learned in doing this project. So I really appreciate your participation all the way through. You've been just such a great contributor. Thank you.
You're welcome, my pleasure.
Absolutely. So I just want to turn to the audience and see if we have any questions for our panelists. You can raise your hand, put it in the chat, whatever you prefer. All right. From our panelists, is there anything else you would like to contribute before we move on? Okay.
I'll
Oh,
add a little
have a
bit.
comment? Sorry.
Um, no, I think it's definitely a good way of promoting change. I think that someone like me being invited to be part of is definitely, you're able to bring whatever you've already been learning into the healthcare setting, and the way that you communicate with, your colleagues, patients. So it's definitely been insightful in that way.
Fantastic. And Kelly, if I could ask you, we did get a question on our registration that I thought was really interesting. How do you train staff on communicating on the topic of hope?
That's a really good question. I think, just speaking personally, I feel that you always want to provide, you always want to tell your patients and families that you want to have hope. We aren't who to say this is the end, or obviously we understand the physiology or the disease process. However, I think we can never take away that hope. I think hope is definitely what keeps a lot of us going a lot of the times. Even though, again, like mentioning it again, even though we understand where something is going to end, being it is a positive end or a negative end, I think hope is what keeps us moving forward, even in accepting what the outcome will possibly be. I'm definitely a person that promotes hope. I think I personally, our family's gone through a very, very difficult time, and I think it's the hope that has kept us going. Sorry, I didn't want to get emotional, but it's the reality of what, like I mentioned earlier, as clinicians we experience, and as community members in very difficult situations, as it is any person experiencing a hospitalization, I think is hope is definitely again what keeps us going. Even till this day, it's not the outcome that we wanted, but it's definitely key, like someone just mentioned there. Yeah.
I agree with you, Kelly. Thank you so much for sharing, and I'm sorry for the difficulty that your family is going through right now. I think Karen Anthony, one of our patient family partners, put it into the chat. Hope is not always for a cure. It shifts with the patient's journey and the family's expectation. And I think that's really a very accurate statement. Very powerful. Anybody else, any other questions? I don't see questions in the chat, just comments and support, which is great. Okay, well, let's move on then to the open discussion portion, if we could. Thank you, Lindsay. You're doing a masterful job, as always. So having heard about our project and having heard about the work of the multi-stakeholder research community and the ideas that we came up with for improving this communication tool, I'd really love to hear from the audience. What are some ideas that you have for improving this tool? And again, you can hold up your smartphone and use the QR code, or you can type into the website slido.com the meeting or the poll number. I see some folks typing, so we'll give you a minute. Mission and staff education. Time for clinicians to have dedicated time to have conversations. I think we heard that time constraint being so important for us to consider, moving forward. Looking for ways to expand beyond the ICU. You're right, it is relevant in all of those conversations, as Dr. Mittman sort of alluded to as well. Create a quality indicator of the use of the tool. I'm interested on what that quality indicator would be. We kind of started to dabble into that conversation. There was an idea to promote patient-reported outcome measures, but what would be that indicator? If you have ideas for that, I'd happy to have you come off mute and share them.
Interesting to do the quality indicator from multiple perspectives. Ask providers who are talking with family members and patients how it helped, what was easy, and ask the patients and family members how it helped, what made it smooth, what made it useful, what made it clear. It's not quantitative data, but
Yeah,
you want to get the sense of what the experience is like from both sides, because that's important.
absolutely. I appreciate that. Thank you, Karen. And I see Karen Fernandez has her hand up.
Yes, in addition to looking at the quality metrics for this, was the tool used? At what day into the length of stay in the ICU was it used? The key members of the team that were present as required by use of the tool, to make sure you've got the right participants there. And was it started on day 2 or day 7, depending on the length of stay? And then you might even, and this would be a hard one, Libby, is diagnosis related, patient with a hemorrhagic stroke, patient with intubated after an overdose. So you want to quantify that a little bit by diagnosis, if possible. Those are my thoughts.
Great. Thank you, Karen. Those are really excellent ideas. I appreciate that. I saw one in the chat as well, on our poll as well. Training in cultural sensitivity and racial diversity and how it shapes communication, I think is really important. And Glenna, I was going to ask the same thing. If the person who put impact of use for LEP, patients and families, I don't know what LEP means. Would you mind coming off mute and sharing?
Yes, it's low English proficiency patients. So it could be deaf, hard of hearing, Spanish, foreign language speakers, low literacy levels, that aspect.
Gotcha. Thank you for that. That certainly, we heard that at our skills exchange quite a bit as well, that this certainly has an impact and something that we need to be conscious of. Absolutely. Karen, did you have another comment? Yeah,
just on to that LEP, use of translation services.
Yep.
One of the things is especially hard is to get translators for the deaf.
Yep. These are all challenges that we certainly need to consider and integrate into future iterations. So appreciate that. Leah in the chat says communication is always a multiple session event. How does this tool help guide that progress? I love that. I think we heard that quite a bit from our patient family partners that, sometimes you give us information, we need a little bit of time to digest it. And I appreciate that concept. Karen, Anthony.
Yeah, also the idea of how this might apply to children as patients, really to anybody that's a patient, but I think that children, because I come from a pediatric setting as an advisor, it's really common for the folks who are coming into the room to talk to the parents and not to the child who is the patient, and figuring out how to make this tool be adaptable for someone who's younger, but certainly able to participate in the conversation.
Great point. others. There's a comment in here, understand the negative connotations associated with the term time-limited trial, but also concerned that other terms are not being as transparent about as it is as what the tool is. Can you come off mute and tell us a little bit more about that concern and maybe the value of keeping the term time-limited trial?
Yeah, hi, this is Todd Neville. I worked on a ATS, I'm a ICU physician and researcher. I worked on a workshop for the American Thoracic Society on the concept time limit trials. And this was some of the things that came up that, exactly what Dawn said, the terms time and the terms limited, the terms trial all like have connotations that the families and patients might not find very pleasant. What Dawn said, the terms time and the terms limited, the terms trial all like have connotations that the families and patients might not find very pleasant. We involved some patients, stakeholders as well. And when we started discussing, well, would you want to know that, this framework is a time limit trial, and there's literature that exists on this already. Would it be offensive that you then later find out that that's what it is? And would you rather be told and discuss with whether this terminology out in literature already is? And basically there was no agreement, but the few patients that were there felt like they would want to be able to look it up and read what a time limited trial is, what is that notion? I think when you change it to make it more broad, the concern then is that loses that ability for families. Like, are they being tricked into something, Yeah,
thank you so much. Great thoughts. I think, and Dong, I don't know if you had a comment, you were leaning in there.
No, I really appreciate that sentiment, Ton. I think we really went back and forth in terms of whether to call it a time-limited trial and stay consistent. I totally appreciate the issue of transparency, especially if family members want to explore a little bit of how decisions are being made. One of the things that we did as kind of a compromise, as you know, Ton, you were involved in the study that we did, was when we were actually practicing it, it was very rare for us to call it a time-limited trial,
right.
although when we did
That's
use
true.
that terminology, we explained it very carefully. And I think being open to the idea that if you were to want to read about this, it is called a time-limited trial, but explaining that we personally don't like that terminology might be one of the ways to get around it. But I totally appreciate the fact that it's a sensitive issue with no good answer.
Yeah, ultimately our group decided that there was no good answer. But I think that's one of the things that if we're gonna move forward to do this as a research and patients participated, I think I would want to be assured that the family, if they want the results of this research, would not be shocked with a paper published with the worst time limited trial on the title.
I so appreciate that comment. And I had not connected the name to this transparency issue that you're raising. So thank you so much. This is why we have these conversations, so we gain a different perspective. And I wonder if your team considered calling it something different, and then yet, as Dong explained, explaining the intervention really carefully and providing that title sort of in the description versus the title. Does that make sense?
Yeah, it does. I don't think we did, because then I thought, then again, like with the transparency and the feeling like a little contradictory here and there. Oh, well, you're describing something that sounds really great, but it's actually a time limited trial, which I have bad feelings about, So we didn't feel like that would be helpful.
Interesting. A great question for us to explore more. I really appreciate that. Other comments?
Can I just add my 2 cents, Libby?
Yeah.
Ton, thank you for bringing that up. I think a lot of the clinicians had the same sort of heartburn when, we talked about changing the title. I think like a lot of things in life, it's the delivery of the conversation. And like Dong described, it's an iterative process, and it's not a one time, we're just going to do a time of trial, done. And I think, the way that we've learned from this project how to be sensitive to patient family member needs, something as simply as giving people more time. I don't think that using those 3 words, time-limited trial, would make or break us in the beginning, but I think we can make or break the relationship if we didn't deliver the conversation in a compassionate way. So I have the same concerns as Ton, but I also, again, I've learned so much from our research community about how we can deliver the message, I think, a little better and more effectively in a more compassionate way. So thank you for bringing that up, Ton.
Great. Thank you, Glenna, for sharing your perspective as well. Anyone else? Any comments or ideas? All right. Well, thank you. We can go on to the next slide. And you guys have been wonderful in providing us a lot of insight and things to think about as we continue to move this work forward. So I'm very grateful for your interactions and your ideas. So in return, it seems only fair that we would offer a few resources. So Glenna, you want to share the resources that we have?
Sure. Again, just to echo Libby and Dong, thank you everyone for your time and your participation, including our speakers. I know everyone's very busy. We know we summarized our 1.5 year work into 1 hour. Great job, guys. But if you'd like to learn a little more and see kind of the resources we gave our research community, we're going to be sending that out to you probably Friday. So the first thing is it's a skills exchange summary. So that summarizes the things we accomplished during that in-person exchange in November, where we all came together in person and learned from each other. The second thing we're going to include is an improv video where Libby and Dong demonstrate a live sort of simulation of a time-limited trial. We use that so that we can help our research community understand what was involved in the actual communication process. And again, Dong has graciously recorded an orientation video, a little more detailed than what he shared today about what the time-limited trial entails. And then lastly, we have a project orientation video that we shared with our research community members to get everyone sort of up to speed what our goals were with this project. So again, I thank you everyone for your time. And again, if you have any questions, now or after you review those additional resources, please feel free to reach out to Dong, Libby, or I. I'm more than happy to answer questions, or if you guys want to be involved in other future projects, more than happy to communicate with you guys. Thank you. And then if we can go to the last slide. Dong or Libby, any parting words? This is from our skills exchange in November.
I'm just always so impressed and so grateful that whenever we reach out to people that represent different perspectives, that the richness of the information in the comments just always is so overwhelming and such a great learning experience for me. So thank you so much for your thoughts and sharing this time with us.
I'll just double down on all of that gratitude thus far and helping us to think in different directions. It's really expands our thinking, so it expands our project, and look forward to more interactions in the future. Thanks, everybody.
Thank you.
Great job. Thank you.